Hi everybody, welcome back to the Code Blue Classroom. Today we're going to talk about the care of the drowning victims. So what are the most important takeaways for the care of the drowning victim? Top priority is airway and breathing management. Take it back to the ABCs, right? Jackson 5 had it right there. Much like our pediatric population, the cause of cardiac arrest is respiratory driven. So hypoxia in turn leads to cardiac arrest. So, some important notes for the ABCs here. If you have airway equipment available, you want to secure the airway. If you don't have airway equipment available, you're going to maintain what airway you do have. Um, and also, please abide by your scope of practice. So, if you're not able to obtain an advanced airway, don't obtain one just because that's what the treatment is. B is positive pressure airway management. So remember all that surfactant and all that foaming that's happening, we need to push that back down. We need that surfactant. You're going to bag through those foamy secretions. Remember, it's surfactant. We want surfactant to stay in the lungs. So push that down back to where it needs to be. Don't suction it away. That's not an airway compromise. That's actually a necessary function for breathing. C, if CPR is required, we are going to do CPR and follow our ACLS or BLS algorithm depending where we are. I think something really important to note here about CPR is don't forget that the drowning victim is wet. So dry your victim before applying an AED because you have a high risk of injuring your patient and potentially any providers helping to rescue the patient. So after our ABCs, what are our top nursing priorities? I think it's important to note that these nursing priorities are important no matter where the patient falls in our drowning continuum. It's really important. Our pulse oximetry, our capnography, our cardiac monitoring, and our vital sign monitoring are all really important. We're going to want to know all of those values and determining whether or not our interventions are effective. Then we head into diagnostics. So we want things like ABGs. This is going to tell us how well we are ventilating our patient. And when we talked about VQ mismatch, our ABG is going to help determine how well this treatment modality is working. So our diagnostic tests are going to be our ABGs, our labs. We do a chest X-ray, and we're going to check a blood glucose. Our chest X-ray may or may not immediately show that there is fluid in the lungs, depending on where we fall in that drowning continuum. Another one for our intubated patients is going to be gastric decompression. So it's important to insert that NG or OG depending on your hospital's policy. Inserting that is going to help with gastric decompression, removing aspirate and excess air that occurred while bagging the patient without an advanced airway. So next is going to be our temperature management. So we talked about removing wet clothing and drying the patient for our AED application, but this is important in also our temperature management. So prolonged hyperthermia can actually increase our risk for our patient to develop cardiac arrest. So our temperature management, warm blankets, warm fluids, in some more severe cases where potentially the victim has drowned in like a very cold submersion type injury, like in ice, we may require some more invasive temperature management methods. Lastly, let's talk about some extraneous nursing considerations. So, drowning can be associated with high risk behaviors. So, patients who are presenting with a story that seems inconsistent with how they drowned, we may want to look at doing like drug and alcohol testing. We may want to assess whether or not the patient had a seizure. This is also where some of those trauma concerns come in, high risk behaviors where someone's jumping off a large height, risk for neck injury, head injuries, or additional polytrauma can happen. So, based on your either in person evaluation or what our pre hospital providers are telling us, we need to utilize that to determine where a patient falls in this continuum. Do we need to be doing a trauma assessment in addition, or do we need to do some other testing to figure out why the patient is currently in the state in which they're in? This is specifically important for, maybe the level of drowning doesn't really meet the picture that the patient's presenting with. For example, a patient was, you know, we've resuscitated the victim after some level of drowning, and the patient remains unresponsive. But at this point, their other lab values aren't indicating that they should be remaining unresponsive. Their ABG is normal, they're ventilating well, they don't require an advanced airway because they're protecting it. In this case, we may want to look for other causes. So this may also look like looking for seizures, cardiac arrhythmias, trauma, intoxication. would be the big kind of four hallmarks to look for there. I think this is where we really need to trust that relationship with our EMS providers and our bystanders and family members. So, people who were there, people who immediately responded to the event, and people who are known by the patient can all give us a wonderful history and background. And last but not least, disposition. Treat them and treat them is often that ER philosophy. So, what do we do? Do we keep the patient or do we send them home? So much of this is dependent upon their continued presentation. I think obviously our intubated patients, we know they're going to head to the ICU. But what about those in between patients, right? And often this is some of our pediatric population. They're mentally appropriate, their vital signs are stable, they're oxygenating well, they don't appear to have any other sequela. You've monitored them for the institution's recommended amount of time for monitoring the patient. So, what do we do? Well, they actually recommend discharge for patients who have been monitored for the appropriate amount of time and are vitally stable. However, for kiddos, we may encounter parents who are very hesitant to take them home because they're concerned about what's called secondary drowning. Secondary drowning is not a real thing. You may also hear it called dry drowning. It's not real. Current literature recommends that we monitor the patient for 6 hours. When a parent potentially has some concerns about this, you can educate the parents that monitoring for 6 hours with stable vital signs, stable ventilation, and stable mental status, the risk is very limited for any sort of complications associated with the drowning event. This is where education is really important, and we need to teach parents for things to look out for with discharge, increased work of breathing, lethargy, behavioral changes. All of these would warrant the parent to bring the child back to the ER. Well, that covers the care and the nursing considerations for the drowning victim. I hope you liked the video today. Remember, knowledge is your best code card. Stock it well. Bye.